Welcome, everybody, and thank you for joining us today for this webinar sponsored by Noelis. It is on hospital-based outpatient ultrafiltration for acute decompensated heart failure, a guide to getting started. Next slide. So before getting into the introduction, just want to present this forward-looking statement by Noelis. Next slide. I'm Dr. Amin Yehya. I'm a heart failure and heart transplant specialist at Sentara Heart Hospital. I'm also the medical director for durable mechanical circulatory support and associate professor of medicine at Eastern Virginia Medical School at Old Dominion University. I'm very well familiar with Aquadex therapy, and we had participated in clinical trials. Lastly was reverse HF trial. I'm honored to be joined today by a group of faculty that have a great resource and input for us that will be helpful to discuss this therapy today. We have Neha Kaur. She is a healthcare reimbursement and operational professional. I also have Dr. Emani. Dr. Emani is a board-certified interventional cardiologist with the Christ Hospital Systems, Heart and Vascular. He is also specialized in a heart failure and heart transplant cardiology. Dr. Emani brings a wealth of knowledge as he was one of the pioneers in leading and spearheading the outpatient management with ultrafiltration and Aquadex at Ohio State University. Welcome, Dr. Emani. I also have Todd Yamokoski. Todd basically is an advanced practice nurse at the Ohio University Wexner Medical Center, Ross Heart Hospital. Todd has been working with medical cardiology, clinical nurse specialist for the last 25 years. And he also worked with Dr. Emani before, and they worked in the inpatient and outpatient ultrafiltration program at Ohio State since the early 2000s. Also, I'm joined by Farah Farouk. Farah is an accomplished leader in market access and reimbursement. She's proficient in contracting, credentialing, provider enrollment, and payment methodologies. And last but not least, we have Kelsey Newell. Kelsey is Senior Director of Medical Affairs at Noelis, and she leads cross-functional initiatives that advance clinical strategy, education, and therapy adoption. Thank you all for joining us for faculty. And next slide, please. So our webinar today will focus on these points, which is understanding ultrafiltration, identifying the right patients, who of the patients would benefit from this therapy, what are the key steps to set up your hospital-based outpatient center. And to set this program, also want to make sure that economics are in place and reimbursement strategies is in effect. We're also going to share some real-world experiences, and we're going to end it with the questions and answers at the end. Next slide. So most of us here on this webinar are familiar with Aquadex system and how it works, but just a quick reminder, Aquadex is a predictable and precise removal of isotonic fluid from the body. So blood is taken from the patient via withdrawal line using proprietary catheter technology. The blood is being pushed through the filter by the blood pump, and the ultrafiltration pump withdraws the fluid across the filter membrane using negative pressure. And eventually, the ultrafiltration pump can pull up to 500 cc's per hour, and the blood is returned back to the body via the infusion line. So it's technically a precise way where we can take a constant amount of fluid per hour from a patient's blood using a peripheral access. Next slide. So ultrafiltration has been proven a predictable solution for fluid overload. A single center study showed that with ultrafiltration, there was 1.74 fewer heart failure hospitalizations at 1 year after Aquadex therapy compared to 2.1 before treatment. Also, this therapy has shown that it can reduce hospital readmission rate when compared to IV diuretics. Around 12.4% was the recorded number of reduction in heart failure hospitalization compared to the national average of 24%, which is really big because, again, our goal as healthcare providers is trying to keep patients in their home, preventing hospitalization, not just because it can cause a lot of economic burden to the healthcare systems, but also it can affect patients' mortality and morbidity by being hospitalized. Subsequently, with reduction in hospitalizations, also they have found that there is shorter length of stay and eventually there is cost saving, which has been estimated to be around $3,975 because again, there's less length of stay and which results in savings basically. Next slide. So Aquadex basically, as we said before, it takes fluid at a constant rate. So there's no fluctuation in concentration of diuretics or volume removal. Hence, it has shown to reduce the neurohormonal stimulation with no significant changes to the kidney function. Also, with Aquadex system, there is importance where diuretics become more effective. I mean, some patients become diuretic resistant, and then when they become diuretic resistant, basically they respond to the oral or IV diuretics, but Aquadex has shown that it can improve the effectiveness to response to diuretics. And as mentioned before, subsequently, there is 53% reduction of hospitalization for heart failure compared to the diuretic donor. So taken all together and knowing how this therapy could be beneficial for our patients, I would like to ask Dr. Emani and to let us know who are the right patients that would benefit from this therapy and how we can, capitalize and helping support these patients.
Great, and thank you for the opportunity and taking your time this afternoon. Of course, everyone's very busy. Those of us on the panel believe this is really a very good way to move into the future for the treatment of our patients. But the question really is, who is that patient? What is the profile that we want that may benefit from outpatient ultrafiltration? I think for those of us who take care of heart failure patients, pretty much all of us on this call, we know the challenging patient when we see them, right? And we've all been there. We've all either fielded phone calls in the outpatient setting, patients that just kind of persistently congestive. We've tried to escalate oral diuretics. We've tried to manipulate their other therapies. Or, certainly in the hospital, we see it all the time. They get a dose of IV diuretics and just not responding the way we expect them to. And I think take your collective experience and really put that together and say, what does that average patient look like, or what is that pattern? And I think you can really start to visualize the type of patient that has persistent volume overload where their renal function, not end-stage renal disease, of course, but the cardiorenal axis has been disrupted. And so they're diuretic resistant. The creatinine doesn't behave the way we want it to, yet we're still not getting them decongested and symptom-free. Those for whom we know them all too well, and I'm rounding this week, and I think we all sort of appreciate, don't say that patient's name 3 times, they're going to show up. And lo and behold, this morning I walk in and there's the patient 25 pounds, 30 pounds up in respiratory distress. And you're like, well, right on time. You were 45 days out of the hospital, and here we are back. A unique and evolving understanding of patients who are going in for cardiac surgery with volume management, where hemodynamics, particularly blood pressure management, may be disrupted by IV diuresis and the vasoactive or the unintended vasoactive consequences of IV therapies. I think that ends up being a really unique patient population. And then we talk here about ICU patients, but really, and through the experience that Todd and I shared, if a patient has been in the hospital and we've used ultrafiltration during their acute inpatient stay, that's a prime candidate to think about outpatient therapy, particularly if they start to have recurrence of their symptoms and we're able to be notified early enough. Next slide, please. So again, clinical markers, I really probably don't have to educate to any great deal this audience, but we, again, know these things. We try to quantify or qualify any of these markers. These are our children, our problem children that we would love to help better than we can. And right, we're all going to utilize escalation of oral diuretic therapies. We're going to add thiazide or boosters to try to help. And sometimes there's those patients that continue to not do well, and we know that they may be headed towards a hospitalization. They've already proven that pattern. So all of these, I would say, as we take care of our patients, you sort of start to create a mental list, or you start to write down and track what can we do better. And outpatient UF, I would propose maybe a wonderful solution for many of these patients. The key in what we have learned from clinical trials, both completed and unfortunately those that may have been stopped early, is that early identification of these patients really allows for meaningful intervention. And that's true across the board. We know that from acute coronary syndromes. We know that from arrhythmias. The faster we can identify, the faster we can deliver therapy, the better we are at breaking them out of a deleterious cycle. Next slide, please. So, I sort of mentioned a variety of different areas, and depending on your own practice pattern, your practice environment, any or all of these can serve as sources to feed into an outpatient clinic. In my experience previously, again, patients who were admitted inpatient either to ICU or step-down levels with significant volume issues where we were utilizing vasoactive medications, IV diuresis, or previous ultrafiltration. Wonderful category of patients. But the surgical step-down units, we mustn't forget, as much as we like to argue, if our nephrology colleagues deal with very much of the same phenotype at times, and we are on the same team. I hope there are some nephrology folks on with us today, and really this is a shared problem. So patients that are calling us or calling into the renal side of things, stating, we're not doing well, but we're trying to balance that cardiorenal fantastic patient population where we can look. And then another place where those of us who have great partnerships with the emergency department, if you're trying to identify patients really at the time of initial presentation and perhaps give them an initial therapy, avoid a true hospital stay, and a quick turnaround to an outpatient UF clinic may be a really nice way to treat that patient and avoid an inpatient stay. Next, please.
So again, this perfect delineation of who can benefit and where we can find these patients. If we want to try to figure out what are the key steps to establish basically an outpatient center. I mean, I know you were one of the pioneers in doing that in Ohio State. If you can share with us, Dr. Emani, please, what are the key steps to establish that?
Yeah, and
Too.
we'll kind of go through some details. I appreciate that. You need to have people who truly believe that we can do this, and we need to believe that this is a good way and an alternative, better way to treat patients. So a champion or a couple of champions for the therapy, again, that can come from physician, that can come from APPs, advanced practice nurses. Todd played a crucial role in building our team at OSU when I was there. The team is really important. We're all going to bring our own expertise. We're all going to help find the patients and certainly going to help manage that patients as we go along.
I think getting buy-in as well from the C-suite or administrative level. We're going to talk about getting a physical space or brick and mortar, and not just that physical space, but bringing in other teams as well. Pharmacy, vascular access may be playing a part as this as well. Getting a nursing staff, getting them trained to the therapy as well. So it's a multi-dimensional team that we need to build even before defining a physical space.
Absolutely. I think I was the last piece of that puzzle, and truthfully, maybe the least important piece of that puzzle to make this happen correctly. So as sort of mentioned, or put another way here, you can see, you got your administrative champions Todd referenced. the buy-in from the system in which you work, especially at the beginning. There are going to be some probably growing pains. There are going to be a lot of whys, and unfortunately, some people will also see that as taking away or deprioritizing something else. Hopefully, that's not the case. But at the end of the day, heart failure continues, as presented earlier, to be a major problem and a major burden on our healthcare systems. So it's usually an easy sell to say, if I can make the heart failure part of our comprehensive care better, I get some priority. And then Todd, and I'll let you kind of walk through anything else you see on that slide, and what the groundwork that you did to help create the infrastructure.
Yeah, I think just defining, again, we'll talk a little more about a physical space, but knowing or kind of defining what kind of program that you want to establish, whether that's preventative or chronic management. Is this a 1 day a week kind of thing that you're going to have available for your patients? Is it going to be a Monday, Wednesday, Friday, Tuesday, Thursday? It's kind of defining or being able to define what you want out of your program, knowing that most organizations don't have a physical space just sitting around waiting for a program to kind of dive in and take over that space.
And speaking from our experience, I think if you actually build it in the other sense, right, the nursing staff, the comfort level with both the patient population, the technology, maintaining vascular access, that may define the space, and then ask, or sort of build into that. When we first started, we used our invasive prep and recovery area. Obviously very well trained in cardiac patients. They understand starting access, IVs, maintaining access. Heparin, not scary. Many of those nurses had come from inpatient cardiology floors. So, I think that worked very well organically for us. As I start to reinvigorate a program at my current institution, we're fortunate to have an outpatient dialysis unit physically on the campus where I am, and it makes sense for all the obvious reasons that they should be part of this. They know how to handle volume removal. They know how to monitor vitals, and they understand the concept of what we're doing. So we're actually going to utilize our outpatient dialysis center here for our next phase. You obviously need the right support people around, a physician or APP champions that can be available to come troubleshoot, to come help identify if there's questions deviating from standard protocols regarding volume removal rates or total volume amounts. And then it was mentioned on a previous slide, the IT support and the order sets that go with that. But the nice thing is, this isn't the same solution for everybody. I think there are many models that could work and should work. Working with your team and understanding how this works best. The ED OBS center may work in some places, the prep and recovery area, outpatient infusion centers, if you've got a great population that gets typically like chemotherapy or other infusions. It's not that far of a stretch to expand that knowledge base to administer outpatient UF.
I think realizing that we ran therapy for about 8 hours. So tying that in as well, knowing that we got to get the patients admitted, registered, in a bed physically, get IV access, get them heparinized. You're talking probably a good 90 minutes prior to actually hitting start on the machine. And then kind of similar as the patients, as we're finishing up therapy, knowing that all in, you're probably looking at 10 plus hours or so. So not, again, the brick and mortar, but having access to that space for that amount of time.
Excellent point. Thank you. And here you can see steps or milestones as we try to create programs, sustainable programs, successful programs. These are by no means an exhaustive or fully comprehensive list, But maybe a playbook to start. What are the things that we should think about and define so that once these patients come in, get identified, we can be the most effective in therapy delivery that we can. You can see there, and I would propose here that your local Nuwellis rep is going to be your most valuable resource to this, to help educate, train, troubleshoot before there are problems, all of the things that we need. The Nuwellis team is fantastic and can actually share experiences, share examples from centers where it is working. Hopefully not too many failure stories, but can share lessons learned from shortcomings at other places as well.
Well, thank you both for this input and insight. Again, it's important to know the patient who would benefit from this therapy and to establish the program. But again, at the end of the day, as Todd mentioned, the C-suite has to approve it, and to approve it, it has to make some financial benefit and not to be like a loss for any healthcare system. So next slide, I would like to have Neha and Farah to tell us and walk us through what are the ways and economics to get reimbursement for this therapy. I think we can start with Neha, and she can share with us some outpatient reimbursement models.
Mm-hmm. Thank you, Dr. Yehya. The clinical piece is always hard to follow, but I do also have some awesome information to share. So effective January 1st, 2022, Aquadex Ultrafiltration has been assigned to CPT code 0692T. Even better news, effective January 1st, 2025, that CPT code has been reassigned from APC 5241 to APC 5242. So ensuring more appropriate reimbursement alignment for the procedure. The APC is going to apply to hospital outpatient services, and this positive change reflects the growing recognition of the clinical and economic value of Aquadex, and it will help support healthcare providers in delivering this important service. So let's dive into the reimbursement landscape. As previously mentioned, the CPT code is 0692T for therapeutic ultrafiltration. The applicable revenue code is going to be 0881. For the revenue integrity contacts that may be listening in, it is a temporary code, but use of 0692T will help CMS collect data to establish a permanent code. So it's very important to set up proper charges for the 0692T code and crosswalk appropriately. For coverage, there is not a Medicare national coverage determination specific to Aquadex ultrafiltration, but several commercial medical policies do exist. You may reach out to me directly and we can provide the coverage policies and additional helpful resources for your specific patient plans. For Medicare payment, we discussed that outpatient services will be paid at the OPPS rate of $1,639. Inpatient service will be bundled into the DRG payment. And for physician payment, very important, Medicare typically does not establish RVUs for T codes. Rather, it will be carrier dependent. So priced case by case basis until the MAC sees a need to put it on a fee schedule. Just a quick example, a professional rate was established by Noridian, effective June 26, 2025, I believe. The physician fee ranges between $80 to $100, just depending on the local area. And for commercial payers, they are going to reimburse according to contract terms or crosswalk negotiations. We will not have knowledge of your facility's contracts. That's going to be proprietary information, but we are able to help navigate and provide resources for requesting contract amendments and inclusion of services. So this was a very quick overview, but my team is here to support your site with any information on this slide. You'll hear more about who our reimbursement team typically meets with from the facility in regards to getting Aquadex set up for success. Farah, take it away.
Thank you, Neha. Next slide. Hi, everyone. My name is Farah Farouk. I'm also from the PRO-spectus team here supporting Nuwellis. Really excited to be on this webinar and be able to speak to what we do. We kind of work with the facilities, as Neha mentioned. Part of the clinical strategy is just getting everybody on board with, understanding the procedure itself. And we kind of help the facilities look at the financial piece of, what it looks like when you're trying to set up these claims and how you're going to be paid. There's different stakeholders on the facility side that we request to meet with in any given situation. Revenue integrity and charge master, this is the team that basically helps that actually sets up the charges based off of the payer contracts, and they will be the ones mapping the charges, looking at making sure that they're being compliant in the billing practices, following what those requirements are from the payer and the contracts. And then also we meet with revenue cycle and billing, and we can guide them with the coding and payer specific requirements, assist with any claims if they're having any issues with underpayments, denials for medical necessity, or for any other given reason. We can also support them at that level. Prior auth and patient access team, these are the people that will review medical necessity before a case actually occurs. And that's where we can help them with reviewing those payer policies, looking for, does it need a prior auth or not? If it doesn't need a prior auth, what can we do to help the facility make sure that they're going to get paid on the back end and not be denied for no prior auth? That's just an example of some of the support that we have in that side. We also meet with supply chain and sourcing. That would be the teams that kind of work on VAC reviews, P&T reviews. We can basically go through all of the information shared from the financial side, just like Neha had discussed on the few prior slides to this one, and basically be there to kind of answer any questions and look at when they are going through what the costs will be versus what the reimbursement will look like, so they can kind of figure out all the finance and put together the pieces before they actually approve the new procedure or therapy at that facility. The last team that we really recommend meeting with is payer relations and contracting. And the reason is pretty clear. They're the ones who have the eyes on the contract, and they know exactly what would be covered, what wouldn't be covered. Sometimes contracts can be very gray. It's very important to kind of look under the hood and see what those contract terms really mean, and then work with those provider relations managers or the contracting reps from the insurance companies, and just understand what your contract really means. Next slide. Thank you. This is just a typical procedure, a process workflow of like how it would look if we were to support an account on onboarding the Aquadex ultrafiltration procedure. For example, we'll have the account manager, which would be your Nuwellis rep. They would identify a new facility for us to engage with. And then the account manager would be providing the relevant contact details for the people that we would need to meet with. And that would be basically anybody from the teams that are on the previous slide. And then we would be able to schedule a call with them and then make sure that the account manager is also there to represent Nuwellis, and then also have somebody from the clinical side to speak to anything if those questions come up. We try to get really prepared before we get on a call with any facility, so we're making sure we're utilizing their time and our time appropriately and have a successful conversation around everything they need to actually look at the Aquadex ultrafiltration procedure. Once we're on the call, of course, we'll be able to answer all those questions, have something to present, and then have a very productive dialogue. And then once they do onboard with Nuwellis, with Aquadex ultrafiltration, we're able to kind of check in with them and make sure that they're not having any issues when it comes to reimbursement. If they have any issues on the claim side, we can assist with that. Hopefully you won't need that if we're doing all the work on the front end. And that's kind of why it's important to have these onboarding conversations and making sure we're actually looping in all those different teams at the facility side, so they're all looking at it and it's not like, oh, we didn't know this before. So we're kind of there to support Nuwellis and all the providers and facilities that are looking to adopt Aquadex ultrafiltration. So we look forward to meeting with you sometime soon. Next slide. This is just a slide to show where you can find us. Neha and myself, we have our contact information on this slide, and also to PRO-spectus. We are on LinkedIn. We have an email for our team. There's actually a bigger team, but we both support Nuwellis, and we're happy to be on this call. Thank you.
Thank you, Farah and Neha, for this very important information because, as physicians, we are not very equipped with understanding the financial and economic aspect of any therapy. We just care about taking care of our patients, but this is also instrumental to be able to figure things out because, again, the only way to do it is we want to make sure it makes some financial revenue or for the hospital to keep it going. On that note, I would like Devin to, advance the slide. And I want to ask, as I mentioned, I started with the introduction that Dr. Emani and Todd were leaders in outpatient therapy for Aquadex. And I want to know, I mean, from their experience, how was it? What were the outcomes and how things, how did they do? So if you guys can share with us your experience, it would be really good, beneficial for us on this webinar.
Great. Well, thank you. And Neha, you said what you presented is actually extremely important because it is the reason, despite some really compelling data, that at the time we were challenged with continuing our outpatient UF program. So the financials are extremely important to maintaining a successful ongoing treatment access to our patients. But here is some real world experience, as mentioned, and thank you for that. Todd, give him all the credit for really kind of helping create a concept, and we had a chance to work together, more than a decade ago now, utilizing outpatient UF. And we took a sample of those patients, the first 14 patients that we had identified that we were trying to avoid heart failure hospitalizations. And we brought them in an ad hoc fashion, got them access, got them hooked up, and delivered 8 hours of volume removal for either 1, 2, or 3 days within a week span based on how much volume we believe they had to give. And we went back and said, how did we do? And you can see here some data that shows that renal function was preserved in the bar graph at the bottom right, with change in weight noted in the middle of the screen. And you could look at the left side there to see a little bit of the details of what we did, about 5-ish liters of fluid out, kind of coming out at just around 2 liters per day, which is what we had targeted. And we had no unplanned 30-day admissions within or a 30-day readmission in about 80% of these patients. And this, if you keep in mind, was a very high-risk patient population that would have been very likely to have been readmitted. Of course, this is a retrospective study. There's no control arm, but it really served as a proof of concept that this could be done. This could be done well, and that we would be able to at least achieve a reasonable degree of success in the targets we were shooting for. And if we go to the next slide, concurrent to that, Dr. O'Brien, who's now my partner here, started a program with a similar idea. Some of the details on how the program was executed are a little bit different, but ultimately high-risk heart failure patients that needed volume removal in the outpatient setting were offered the opportunity to come in Tom's program. They were scheduled almost like a dialysis light to come in and get outpatient UF to just avoid that worsening heart failure status. So whereas in OSU, we did 1, 2, or 3 sessions and then set them back on their oral diuretics. And we did have a couple of repeat customers, maybe a couple of months later, that were starting to get back into that cycle and were offered outpatient UF again. What Tom and his team did at the time was said, you know what, you're at a high risk of coming in. Why don't you sort of come in every so often and get a tune-up? And similar good results, a 50% decrease in hospital admission rates, as you could see there. Again, a very high risk population where you'd be expected to see them frequently. And not only that, the number of hospital days, should they get hospitalized, came down as well. So again, another nice proof of concept in a small controlled environment to say that this could be done. Todd, I'll throw it to you to see if you have any insights from our experience that you'd like to share.
Yeah, I think the majority of the patients that we saw in our program, we knew well. They had been previously discharged. I'm not going to say that we didn't bring in patients from clinic, but I believe these were all patients that had some evidence of diuretic resistance. So we knew them. We knew that they responded well initially to an inpatient treatment. and just had a feeling, like you said, our goal was to prevent that bounce back readmission. And I think we were able to show some success. I think kind of adding on to what you said, having patients come in for a couple treatments during the week allowed us, and I know we skipped a little bit through, and maybe some centers will have some questions about what IV access is correct for the patient or right for the patient, knowing that some are short-term or short duration access as opposed to, is this patient that we are thinking long-term outpatient ultrafiltration that we're going to need multiple weeks for this patient, really will guide us into what IV access we would need for that patient. So is it a short-term thought? Is this a long-term option for the patient? Really kind of guide some of those other decisions. Yeah.
Can you elaborate a little bit more, Todd, about getting these patients, how the flow was? I mean, how long the therapy lasted and the timing?
Yeah, I think our goal was initially to set the ultrafiltration removal rate to 250 an hour. It didn't mean we couldn't go up or down, but really the goal, and I think the data show that we were able to remove upwards or over 2 liters of fluid on these patients during each of their treatments. Again, that meant for our center, for our program, that we were bringing the patients in probably early in the morning. Again, if we already had established IV access, it may have meant just getting the patient heparinized. We did heparinize all of our patients during their treatment. So again, another team member that we had to be on board with was our pharmacy team, and making sure that that was built into our order set as well. Put them on cardiac monitoring, not overly aggressive on vital signs or hemodynamics, but having access to that information, getting an admission weight or pre-treatment weight and a post-treatment weight. So we had a pretty close eye. I think we monitored or measured their chemistries as well, just to make sure we weren't having any significant impact on their electrolytes or their renal function.
Yeah, and I'll add, on that cohort that we studied, the vast majority of them got IV access established as part of that intake early in the morning. It was a mix between the prototype of the Delc catheter, the midline designed for UF, or 2 18-gauge peripherals. There were just a couple, because of their underlying disease processes or other reasons, actually had tunneled lines already established that we were then able to utilize for that. But that was not the rule in the cohort which we had. They would come in, get their access. If we knew that they were going to have consecutive days of therapy, and we did the DELC, we would dress it like a PICC line, send them home, have them come back next morning, make sure it flushed and was ready to go. It's not quite a PICC line, it's not quite a midline, but if it's in a very short period of time, we were able to treat it as such and had no infections or other vascular complications related to that strategy. If they were going to go home for 3 or 4 days before their next treatment, or we would not send them home with it.
Mm-hmm. We'll probably have more questions to come in the question and answer section about duration, how long the patient will last, who monitors these patients, how long you're going to continue with it, and what are some markers potentially that can come up with it. So next slide, I think we have to have a key points to have a successful implementation plan. As I mentioned before, and as everybody mentioned, we have to have the right people on the table who can make a decision and get everybody on board, because again, we want decision makers who can help push the needle and advance the care for our patients. As Todd and Dr. Emani mentioned, we need to have appropriate space. We need to select sites. I mean, in Ohio, they had their outpatient dialysis center. So we need to find a place where we can put these patients in dialysis centers or infusion center, how we can establish it. We need to have, as Todd was mentioning, have a room, you're gonna have vascular access, they might need to get heparin. So again, we need to have a place that can support all of these requirements for the machine. And again, to do all these stuff, we need to have a workflow because, again, patient safety comes first. And it's important that we want to make sure we have a clear and well-defined pathway that can help us, prevent any hazard like safety issues for our patients. Make sure that, the access site remains clean. There is, no contamination, no excess bleeding. Staff are comfortable with the therapy, are trained well on it. We have the EMR basically are able to support this. There's communication between the providers. So make sure, again, everybody is on board and knows the plan and why the patients are there. So building that workflow is instrumental. And, having all these steps, alignment, having a place, and building the workflow is important. Also, too, we need to have the finance aspect of things, as we had Neha and Farah talk to us about it. When we have everything, the ducks in order, then we have to get launching. And the launching, basically, we have to identify at least a first patient who we think who can benefit from this therapy. And we have to kind of see if it works and how it works. Sometimes there might be some kinks on the road, but we need to learn how to overcome them. And the only way to know how to overcome them is to experience them. And to experience them, we have to identify somebody who can be undergoing this therapy. So again, we have to have in transition and communicate the rollout plan across time and make sure this, we revisit all the time, make sure we are on track. So I think these are the key steps for a good and successful program. And before going to the question and answer section, I want to ask Kelsey to share what is coming this fall with Aquadex.
Thank you. Yeah, we are excited at Nuwellis to make this work in the outpatient space. And one of those things we understand with these shorter treatments is the 72-hour circuit is maybe not necessarily what's needed. We really only need a shorter duration therapy circuit. So we have decided to come out with a 24-hour circuit, which would allow you to do that shorter run for that outpatient treatment. Again, if there's other needs for a shorter length circuit, then we would have that. But we will still offer our 72-hour circuit for that multi-day extended inpatient type treatment. And this 24-hour circuit will actually be at a reduced cost as well. So we will release more information about that time frame. We're hoping early this fall, as well as some of the things related to pricing for the circuit itself. So more
exciting news. Thanks, Kelsey, for sharing.
Yeah, thank you.
Thanks, everybody. So now I would like to go to the audience and please write your questions in this chat section, and we're happy to answer any of your questions. But before going to the, that and getting your questions, I would like to ask, Kelsey, since you talked about this, the access site catheter, but I just want to know, how Nuwellis as a company will support any program, to establish a successful program for our patients, what the company has to offer technically.
Yeah, thank you again. And Dr. Emani, thank you for the plug. We do really want to be a partner in working with your sites and your centers to get your outpatient programs going. We have a clinical team as well as a sales team that can help support both the business and the clinical side. Our clinical team really focuses on what you need to have in place, those key factors we talked about: access, anticoagulation. They can help with the questions with providers and policies, procedures, documentation. Sometimes you may already have an inpatient program and we just need to edit it and transition it a little bit. We have some order set samples that we would be happy to share. And oftentimes it might be connecting you with another site that is already doing outpatient. And then from the business side, as we said, determining what your sort of needs are for whether you need the 24-hour circuit that's coming and or that longer term circuit, but also, do you need more machines? Can we do rentals? Do we need to place more machines under a procurement process? So all of those things, questions that can be answered, but also really supporting you from that planning phase through to the actual implementation, having a Nuwellis rep on site with your first outpatient treatments to ensure that they understand the pump, that the nurses have been trained, and any questions they may have about supporting that patient as well. So we really are from start to finish, all the way through from that first planning phase to the first patients. We will be there and we will answer any questions you may have. So
Thanks,
please
Kelsey.
reach out to your reps.
Yeah. Just a question from Pam Davida Dials at Christ Hospital. She's asking how much training time is involved for the nurses usually take, and I'll feel it to Dr. Emani here from Christ.
Actually, I'm going to punt that too to our Nuwellis folks too, because I know from a couple of empiric cases, depending on the background, and I think certainly Pam, your team would catch on pretty quickly. There are some nuances to this particular circuit setup that I don't think would be too foreign. And then the training in terms of monitoring flow rates, monitoring volume removal rates. Again, coming from a dialysis program, you guys could probably teach us more than we could teach you on how to do that. But Kelsey or from the Nuwellis team, in your experience, have you seen sort of an average amount of time or time per unit that it takes to get everybody comfortable?
Yeah, if you are talking about dialysis trained nurses or even extracorporeal therapies, perhaps CRT and ICU level staff, we see that really about an hour to 90 minutes is needed to train the staff. We do a little bit of talking about the why and the who, which will be established through your program, but then we spend the majority of that time loading, priming, and troubleshooting, which is really, at the end of the day, you have to be able to troubleshoot for it to be successful. So that's where we focus a lot of that time. And we can do it in multiple sessions to make sure we get all of that staff trained, or sometimes we have some scheduled well out in advance. So it's really, what does the site need, and we want to meet that need. But I do want to actually push this to Todd as well and ask, what did your staff and your nurses need to be able to successfully roll this out and run the device?
As Dr. Emani had mentioned, we were maybe lucky to have a lot of our staff in the prep and recovery area that had seen it before, had ICU experience. Like you said, I would have guessed out of the gate maybe an hour or two of training. Nothing unique to an outpatient treatment that if your staff is already trained on the device in the inpatient setting. So the carryover, other than running for a shorter period of time. Anyone with background or experience in extracorporeal therapy, dialysis, I think the concept is it falls under the umbrella. So it's really just a matter of pressing the button, seeing the device or console set up, loading the circuit, and just getting comfortable, like you said, with troubleshooting.
So one question comes up, and is that when does the therapy ends and how long it lasts? And also, we touched upon anticoagulation. Can you guys talk more about the anticoagulation aspect? I mean, these patients need to be on heparin drip. Can you elaborate a little bit more on that?
Yeah,
I'll just say, I think our
Yeah,
I think we're just using kind of the cardiac nomogram, the 12 to 16 units per kilo. We typically would ask that if the patient was coming outpatient, that we would try to establish access and get heparin started at least 30 minutes before we hit start on the UF machine, just to give kind of grease the skids, get the patient heparinized a little bit before we hit start, so that we could ensure that we would not have any flow issues.
Yeah, I'll add that we had a couple of that was our standard and the default for most of those patients. Standard cardiac, again, familiarity to many of the nursing staff has worked well in our experience to keep the circuit running on our inpatient side. There may be some subtleties. Patients who are on chronic anticoagulation for other reasons. We had a modified flat rate heparin infusion. We would attempt to not disrupt their long-standing anticoagulation so that we don't put them at risk for the thromboembolic complications, on the indications. So warfarin, for example, if their therapeutic INR was 2 to 3, just keep taking your warfarin the way you should. And then we would add just a little bit of a non-titratable heparin into the circuit to keep the circuit flowing. This may
What
be
about DOAC? What about DOACs? If
yeah, I was gonna say, so this may be modifiable, but DOACs were not in wide use at the time that we were doing that pilot. And really that may be a discussion that if the plan is to use a vascular access like the DEL, how comfortable are the vascular access specialists in putting in without disruption of the DOAC? And then I would say I would still probably put a flat rate heparin in at a low dose, because I believe it does kind of help prime the filter and keep it from clotting in real time. Or if that were, something where access would become challenging or undue risk while on the DOAC, same for other invasive procedures. Do you hold it for 24, 36, or 48 hours for a venous access? Here we typically hold DOACs for 36 to 48 hours for invasive venous procedures.
So eventually, for example, if you want to have these patients who are going to stay for 8 hours to get 2 liters off, and some patients are diuretic resistant, as you mentioned, some patients are frequent flyers. Do you think maybe a more temporary access like a tunneled line or TDC or whatever it is, have you guys used it or just all peripheral?
Yeah, I think there are selected cases where we have, the true frequent flyers, those that have challenging vascular access. Let's say they're sort of in that CKD, and this is sometimes a challenge that those that follow with nephrologists don't want to have repeated peripheral vascular access in case something were to change in the future. If the patient's willing, the tunneled line from a technical aspect, in my experience, works extremely well. It's a fantastic access to run Aquadex. The patient has to get it put in and then care for it and keep it clean and not infected in between uses. So I think from an individualized standpoint and a specific patient management standpoint, if that is deemed appropriate, I would endorse it. I think it's a good thing. Todd, you were there for a couple of those patients where we put in tunneled lines.
And I think kind of piggybacking on that is making sure you have the right team members. If you at your organization have access to APPs who can place central lines, we certainly have that here in our inpatient program, where our heart failure APPs are credentialed to put in lines. That maybe just takes another piece out of the puzzle. I think there was a question I saw that popped through about how often are we changing the circuit. Ideally, not at all. Usually we were able to get an 8-hour treatment off of one single filter. And again, it all kind of goes back to adequate IV access and adequate anticoagulation always determines how well your therapy is going to run and how viable your filter is for that treatment.
Thank you, Todd. And Kelsey, have anything to add on that part?
I do. Our anticoagulation strategies have progressed as the medications have also come to market. And you mentioned the DOACs, and we have seen that some centers and in Europe, they have used a combination of DOACs and Lovenox, or what our sub-Q. They are able to administer that to the patient prior to the treatment, as well as maintain them on their DOACs. And then we do see that the priming of the system with a heparinized saline once and or even twice through prior to connecting really does give you that 6 to 8 hours of filter protection. The patient would indeed get a very small bolus. That concentration of prime fluid would go to the patient, but again, it's not continuous. It's just that one time upon initiation, and we find that both the filter and the patient do quite well for those shorter run 6 to 8 hour treatments.
Thank you. I have one more last question before closing, and it's for Farah and Neha. Basically, is there a go-to resource for reimbursement? Can you just share with that in a very short period of time? How do providers handle billing and coding for this therapy? Basically, is there a way like for it?
Yes, so that's a great question. Nuwellis provides several reimbursement resources, including a detailed guide, and our team at Prospectus. We are able to meet with you virtually to get your facility onboarded and kind of provide a checklist of to-dos, including charge setup for 0692T. We can discuss coding, payment concerns, coverage. Honestly, wherever your need may lie, we are happy to assist.
Great. Well, Farah, you want to add anything else, or
I think we covered everything in the slides, but if there's any questions coming out of this webinar that you would like to address, because it is a lot of information. And of course, if you're not really, in tune with what the reimbursement landscape looks like, we can work with your payer relations and contracting teams and look at your specific payer mix and kind of share our guidance on what we see with specific payers and how that looks. And of course, you have to think about inpatient versus outpatient because that changes the dynamics of the reimbursement very, by quite a bit actually. So it's very important to review those contracts and just see like if any payers are changing anything in your contracts, you want to make sure that you understand what the impact of those changes are.
Sure.
We've seen sometimes where a commercial payer might say, hey, we're going to treat OBS like an inpatient stay. And if that's following Medicare, that's not correct. Like Medicare will, you have to be following the 2 midnight rule. So there's like a difference there. And there's a lot of gray when it comes to contracts. Sometimes, payers don't really put everything down in the contracts and they leave it gray. And it's for us to figure it out. So we can kind of help you at that level as well. Like that's how deep our assistance is. So we're happy to meet if with any questions when it comes up.
Thank you so much. So thank you everybody for joining us today for this webinar. Thank you, Dr. Emani, Todd, Farah, Neha, and Kelsey for joining us and for making a valuable presentation and productive discussion as we saw. For you who are registered to this webinar or that you had to step out or missed part of it, it will be basically available on demand shortly after we conclude today. You can also watch it when able and at your leisure. Also, Nuwellis will be sharing the content of this webinar on its website and via social media channels as well. In addition to today's webinar, Nuwellis will be sharing a series of white papers in the coming weeks that provide further details on what we discussed today. So it could be a good reference for you or your team members. And if you'll be attending HFSA in Minneapolis at the end of September, Nuwellis will be hosting a dinner. Dr. Emani will be giving a talk. So you can reach out to Nuwellis rep directly for reservations. Lastly, if you'd like to speak more about setting up an outpatient ultrafiltration program, you can reach out to your Nuwellis rep or email us at balance@nuwellis.com. You can email the Nuwellis people again at balance@nuwellis.com or reach out to your representative. Thank you, everybody, for joining us today, and have a great rest of your day. Thank you.
Thank you.
Thank you.